Wonderful talk, Dr. Sharma. And now our next speaker is Dr. CHINTAN Singh. She will be talking on fibrin glue and amniotic membrane assisted for this corneal thinning and perforation management. Over to you, Dr. CHINTAN.
Thank you. And I'd like to thank AIOS and Dr. Shok Sharma for this opportunity. Dr. Sharma himself has a lot of experience in cyanoacrylate glue as well as fibrin glue, and in fact his was one of the first publications which came out comparing fibrin and cyanoacrylate glue. So we know that in most of the situations for corneal thinnings and perforations, usually we go ahead with the cyanoacrylate glue. But there are certain situations where fibrin glue definitely, even in perforations, can be helpful. And of course, amniotic membrane we know has a plethora of uses which we are using across all kinds of surgeries. So fibrin glue, we basically know just a little bit of the background, is a biological tissue adhesive, and it is biodegradable, unlike the cyanoacrylate glue, which is non-biodegradable. And basically, it makes use of the coagulation cascade, the fibrin glue, to achieve closure of the perforations. So there's no financial interest. We have the commercially available preparations. We have the TESEAL by Baxter and the Reliance ReliSeal. The inherent components of both are same. For example, in the Baxter, we have the main component, which is there in the large blue bottle, is the sealer protein concentrate, which has a lot of substances, the main of which are the fibrinogen, which gets converted to fibrin. Then we have the plasminogen, fibronectin, and factor 13. Along with this, we have aprotenin, which is derived from a bovine source, and basically it acts as an anti-fibrinolysis. So once we have the fibrin clot, we don't want it to get lysed very soon, and so aprotenin helps in that. So the blue bottle for the preparation goes to the blue bottle. And then with the second component we have is the thrombin and the calcium chloride. So these get mixed with each other. And for the fibrinotherm, the TESEAL fibrin sealant, you have the fibrinotherm sealer or the warmer. In fact, now I think they've changed the composition a little bit, so you don't really need this. Gentle shaking also helps. But basically, the components are pre-warmed in this warmer first, and then it gently stirs the components. The important thing is that once this fibrin glue is formed, it must be used within 4 hours of preparation. So we cannot really take it, have it formed once and then use it. If you have it in the morning OT and then use it in the evening, because its quality will go down, it may not coagulate as well. The unprepared, unopened kit can, however, be stored at room temperature, which is not the high room temperatures we have in North India, but temperatures between 2 to 25 degrees centigrade, or it can be even refrigerated. So it's important to know the differences between the fibrin versus the cyanoacrylate, because the characteristics are a little different. So fibrin induces less vascularization and less, consequently it causes less irritation because it doesn't form that hard clot, and it induces less giant papillary conjunctivitis. It causes minimal inflammation. The surface is smooth, so the patient is more comfortable. It's perhaps easier to apply, but it has no bacteriostatic action, and it degrades quickly, so it can't do for very large perforations. On the other hand, larger perforations, I would say. On the other hand, the cyanoacrylate is a stronger adhesive. It lasts longer. If applied well after proper deepithelialization, we know sometimes for months it doesn't detach. And it also has an antimicrobial effect. So as shown by Dr. Sharma, we can use it in infective cases. It induces vascularization, which sometimes is a good thing. The vascularization helps the perforation to heal a little bit, but sometimes that vascularization can be a bit too much. And so that sometimes, so one has to balance as to when one sometimes need to manually take off the glue as well. And also because of its irregular surface, it's greater discomfort if not applied properly, so it has to be applied as a very, very thin and flat sheet. The amniotic membrane is something which we cannot do without in basically the cornea practice. One could have the cryopreserved amniotic membrane, which is more easily available in larger institutes where you have eye banks and it can be prepared. Or nowadays we have the dry form of the amniotic membranes, which are also available, and in fact I forget the name of the company. They have amniotic membranes of different thicknesses incorporating different layers. So the amniotic membrane basically has a lot of growth factors like the epidermal growth factor, the hepatocyte growth factor. It has chemokines and cytokines, and it has, again, a multitude of functions. So it promotes epithelialization. Basically, the amniotic membrane is divided into the epithelium and the basement membrane and the stroma below, as shown in the diagram on the top. Usually, as we de-epithelize the amniotic membrane and preserve it, but we have the basement membrane, which is the most important, which acts as a scaffold for the epithelial cells to grow. And then we have the stroma, which acts as a sink for all the inflammatory mediators on your ocular surface, and as well as it helps in tissue building when we use it as a tissue substitute, as I'll show. So overall, the amniotic membrane promotes epithelialization. It is anti-inflammatory and anti-angiogenic. It has antimicrobial properties. It can be used as a biological contact lens, especially when used with the basement membrane side down and the stromal side up, and it is a tissue substrate. So there are various techniques of amniotic membrane placement. It again is useful to know these. You could use this as an inlay. So once your amniotic membrane is smaller than the size of your defect, and you use it with the basement membrane side up, then the epithelium of the surrounding tissue tends to grow over it, and it adds on to your tissue, and there it's used as an inlay, and it's trimmed to fit the size of the defect. The diagram in the center shows when you are using it as an onlay or a bandage contact lens, like I was talking about. So it acts as a temporary biological dressing. You keep it larger than the epithelial defect or your tissue defect, and you keep the basement membrane side down. What that helps is that the epithelial cells from the host tissue grow under the membrane, not over the membrane, because here you are using it as a bandage, kind of a band-aid kind of a thing. And then you could have combined techniques where you have a lot of tissue loss, where you use it as an inlay plus an onlay. And here again, it's some people say it's not really important which side of the membrane you use, but I think it does make a difference, and we all know that test where we try to see a dry sponge and soak the stromal side comes up like vitreous strands, whereas the epithelial side does not come up. So it's nice to know the orientation, and then it can be used as a single layer or a multiple layer. So now, in which situations do we think of amniotic membrane and fibrin glue for corneal perforations? Like I mentioned, not all, but there are some specific conditions. For example, if you have a small non-traumatic perforation with a loss of stroma, where you know that providing support for a few weeks will allow the host tissue to grow in. There's one. Desmatoseals is another condition where amniotic fibrin glue and amniotic membrane can be useful. Here, sometimes applying cyanoacrylate glue can lead to rupture of the desmatosele, and in fact, you end up with a larger perforation. And also, when you have impending perforations and the stroma, there's a lot of stromal lysis in the surrounding tissue, for example, in some immune conditions. So your fibrin glue plus amniotic membrane helps to be anti-inflammatory as well as get incorporated. Also, the amniotic membrane is easy to shape to the area of the tissue loss, and it may be used you can use it as a single layer, or it can be used in multiple layers, or it can be used as a plug. So this is an example of a 16-year-old male who presented with diminution of vision in both eyes. Surprisingly, he was from a well-educated family, but he had history of itching and rubbing of both eyes since childhood. And in the clinical picture on the top, one could see that there was extensive vascularization. The child was not able to open his eyes at all. And there was the iris plugging the corneal tissue, which we can see on the ASOCT also. The chamber was well formed, but the eye was per se soft, and on Seidels, it was on Seidels with pressure, the Seidels test was positive. So this was a young child, now 16 years old, who needs some intervention, otherwise the chamber is formed. So we need the anti-inflammatory effects of the amniotic membrane here, as well as we need something to seal the perforation. So we went ahead and did a fibrin glue. One can see the extensive vascularization here. So this epithelial plug was removed. A little bit of air injected. Then these adhesions had to be separated. And again, it's important to dry the area. Then a bit of fibrin glue was placed on top, covered by the amniotic membrane. So that would also help to take care of a surface. It's acting as a contact lens. And the amniotic membrane was applied in 2 layers, 1 layer over. So here, basically, the amniotic membrane is not being incorporated into the tissue. It's acting as a bandage. The fibrin glue is acting as the plug. And so this was the picture. So at presentation at the first day, and at 2 weeks, one can see on the ASOCT that some of the tissue, and of course, along with the other anti-inflammatory measures which were given to control this allergic conjunctivitis, the tissue, there was remodeling of the tissue, and the patient has been under a follow-up and doing reasonably well. So now, can amniotic membrane and fibrin glue be used for large corneal perforations? The success of amniotic membrane varies with the size of the perforation, and it's been seen that it has only a 40% success in perforations which are 1.5 mm or larger. So in these situations, definitely cyanoacrylate is better. But in micro perforations, the success is 90 to 100%. When I talked about multi-layered AMG, there are practical problems in using multi-layered AMG because the amniotic membrane, all of us who use it know that it tends to slip over each other. So it's difficult to manipulate and the layers keep sliding and slipping. And in large perforations, amniotic membrane is not able to give us this support. So the Tenon's patch graft, which has recently been described by Dr. Namrata Sharma and others, and that will be a better situation, or the scleral patch graft as shown by Dr. Sharma would be a better situation in these cases. The other thing one can do is a fibrin, sorry, I'm running out of time. So fibrin glue can be used in multi-layers. First, you can stick it with the glue and then use it. That will make the handling easier. So this is an augmented fibrin glue. And just a small example, I think I've run out of time. It can be used. So in cases of large corneal thinning, one can make a groove, and this amniotic membrane can be applied. I'll just take 30 seconds more. Applied in different layers. One can use a combination of fibrin glue as well as sutures, and this can be put in place, and this is the patient healed later on. I will skip this video. It can be used in shield ulcers as well. And so in conclusion, we can have small perforations, we can have fibrin glue plus amniotic membrane. In larger perforations, we can have the fibrin glue assisted augmented amniotic membrane. And the technique of application, that is important. It has to be modified per patient, and it has to be modified on a case-to-case basis. You can't have one size fits all, but a combination of amniotic membrane and fibrin glue is definitely very useful in certain cases of perforations and stromal thinning. Thank you very much.
Thank you, Dr. Chintan, for excellent presentation.